हेलो यस मैम कर लिया और लोग आने लगे आप आइए गुड इवनिंग निमी मैम निमी मैम कैन यू हियर मी योर ऑडियो इज नॉट देयर
I had muted. Is it okay? Pankaj, can you hear me?
Tarun, can you hear me?
Yeah, you're audible.
Yes, sir, I am hearing you. Yes, sir, I am hearing you. Good evening, sir. Sir, you are audible, sir.
The Pankaj is not audible, I think.
Is audible, sir.
So we are about to start.
Hello. मेरे पास आपकी इनविटेशन तो है नहीं सब लोग आ रहे हैं आपका नहीं आ रहा
Dr. Dipankar, am I audible?
Yes, ma'am, you are.
Okay.
I can hear you.
Okay.
This is Nimi here. Good evening, ma'am.
Good evening, Dr. Nimi.
Nimi ma'am, can you hear me?
Yeah, you're audible. Absolutely okay. I think you cannot hear our voice, I think. 1 minute. Is it okay?
Yeah,
You're
now it is
audible
okay.
here.
Yeah.
Okay. Shalu ma'am has joined?
No, Shalu ma'am has not joined.
So we're waiting for her.
Where is the option to present here if I have to present? Okay, it's here. I'll just put the main slide and I'll just check if it's working.
Yes, ma'am.
Can everybody see my screen?
Yes, ma'am.
Yes.
And can you see this?
Yes,
pointer?
Dr. Neha.
Can you see this pointer also?
Yes. Yes, Dr. Neha.
Okay.
Just cancel it. Let me first accept everybody.
Sure. I will just check. Just a second.
Yeah, it's moving.
Okay. And how do I stop this?
Dipankar, some sound is coming.
What type of sound, ma'am?
Some background sound from somebody. Have you muted everybody?
Just a minute.
I'll just mute my stuff. Time being.
Dipankar is already 5-2. Time limited is there in this?
हाँ जी मैम.
You should better start.
नहीं मैम, अभी तो 32 ही लोग हैं.
Okay. No, I'm just asking. The time limit is there? 1 hour only?
नहीं, XOS वाला है ना. एक सेकंड.
अच्छा, then it's okay.
नहीं, यही है मैम. Yes, sir. You're saying something, sir? Yes, sir. Yes, sir. Yes, sir. Tell me, sir. Good evening, sir.
Good evening, sir.
Yes, sir. This link is different from YouTube, sir.
Yeah, but most of them have joined through YouTube also, Dipankar.
Yeah. I'm just waiting for Shalu ma'am to join and then I can start it.
Fine. Yeah.
Mimi ma'am, can you please send the link again to her? Somewhere she's facing some problem with the link. Link to her so that she can join.
Okay. I'll just go. Done.
Mimi ma'am, can you see my screen now?
Yes. Yeah, I can see. No, why I'm. Yeah, I can see the screen.
You were able to see it?
Yeah.
Okay. Still, I have cancelled it. Just waiting for Shalu ma'am to join.
Yeah, I've sent her this link, but she's not seen yet. I'll just call her once.
Yeah, please call. हेलो मैम, मीटिंग कोड कोई नहीं है, बस आप लिंक पे क्लिक करिए और हो जाएगा। आपको निमी मैम ने फिर से भेजा है। आपको निमी मैम ने फिर से लिंक भेजा है, वो आपको कॉल कर रही है। हेलो, अभी तक नहीं आया। मैंने आपको मेल पे भेजा है, फिर से लिंक पर देखिए। अभी मेल पे भेजा है मैंने, फिर से। लिंक आया है, जीमेल पे मैंने भेजा है, dr.shaluga@gmail.com। ये नहीं है आपको, फिर से भेजता हूँ। मेरे पास 36 लोग ही हैं। बहुत सारे लोगों ने यूट्यूब पर ज्वाइन कर दिया। ठीक है, 35।
सर सर मैंने अभी एक लिंक भेजा है सर, उस पर क्लिक कर देंगे, वो अपने आप ज्वाइन हो जाएंगे मैडम। सर
जीमेल पे आई आपको कोई रिक्वेस्ट? एक बार फोन काटता हूँ, शायद आ जाए।
सर
Yes, Tarun.
मैडम मैंने भी
हाँ.
एक बार मैडम को भेजा है
अच्छा.
व्हाट्सएप
Yes, Dr.
तो
Tarun.
देखिए मैडम वो सर मैंने भी मैडम को भी भेजा है व्हाट्सएप पर तो
अच्छा, I'll
Just
just try.
call her and tell her because she's not getting it.
एक मिनट
Dr. Saurabh, ask everybody to join. I am not getting the invites.
I think most of them have joined through YouTube also, Dipankar. So
People are writing on chat that they want to join, but I'm not getting the invitation to join the meeting. जी मैम क्या करूं मैं? नहीं हो रही है नहीं मैं देख रहा हूँ नहीं मैं सारा ओपन कर रखा है तरुण ने भी देख लिया आपको शायद बात करिए उनसे जरा। Nimi ma'am, any idea how many people have joined on YouTube?
I'll just ask. Krishna sir must be knowing.
Okay,
I think more than 25.
25.
More than that, I think.
Because 35 are here only on Google Meet.
No, what I can say is
Dipankar, my senior is also trying to get connected, but she's saying that nobody is accepting the request. I don't know why people are not able to join. I think there is some issue. Trying for some time, not able to join.
Shall I restart the meeting?
It's up to you if you feel that we should restart.
Yeah,
Right.
Dr.
Please.
हाँ जी बताइए एक बार मैं फिर से मीटिंग शुरू करता हूँ फिर आप ज्वाइन करो 1 minute let me restart it again Nimi ma'am I'm restarting the meeting okay
most of
let
them
us
are
all
waiting.
join it again
Yes, sure. Okay.
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 Sir?
Hello, can you hear me? Hello,
Yeah.
Dipankar, can you hear me?
Yes, ma'am.
Dipankar, am I audible?
Madam.
Good morning. Good evening, Shalom. You are audible, ma'am.
Good
You
evening,
are
ma'am.
audible. Good evening,
Dipankar,
ma'am.
Good evening, ma'am.
Dipankar, अब आ गई ना मैं?
Good evening, ma'am.
Yes, ma'am, we can hear you. You're audible.
Yes, ma'am.
Good evening, everyone. I'm sorry,
Yes, ma'am.
Good evening.
No, ma'am.
Good evening, ma'am.
some technical issue.
So, Dipankar, I think we can start now.
The speaker is here.
Hello. Yes. Good evening, ma'am.
Good evening, Mimmi.
Ma'am, shall I start? I can't hear Dr. Dipankar. Your
Dipankar, can you start? Camera is not working.
Yes, ma'am. Can you hear me?
Yes. No, I think we should start now.
Still people are coming. We are 99 at present. Ma'am, may I start?
Yes, you can start now. Please start.
Okay. So good evening, one and all. On behalf of IAOMR, I welcome you all to the fourth webinar of the IAOMR online lecture series titled MRI, Unravelling Maxillofacial Region and Explicit Clinical Tool Revisited by Dr. Neha Koshal. The speaker is a young and dynamic lady, an alumni of Bapuji Dental College and Hospital, Davangere. She is a consultant maxillofacial radiologist at Atulya in Chandigarh and an excellent orator. I would also like to apologize for the delay in certificates of the last Hemant Umarji. Due to more than 400 participants together on Zoom and YouTube, considering the overwhelmed response, we would be issuing a link to fill in your details towards the end of this lecture to ease the process of certificate distribution. Without taking much time, may I now request Dr. Shalu Rai, Professor and Head, Department of Oral Medicine and Radiology, IDST, Honorable General Secretary of IAOMR, to please introduce our guest speaker for today. Thank you.
Good evening, everyone. Am I audible?
Yes, ma'am.
Good evening, everyone. On behalf of Indian Academy of Oral Medicine and Radiology, I welcome you all to the fourth online webinar series. Today's webinar series is done by a very dynamic lady, Dr. Neha Koshal, who is a dentomaxillofacial radiologist with a master's degree in oral medicine and radiology from Bapuji Dental College and Hospital. She has learned the art of reporting and interpretation of CT scan and has joined a number of diagnostic centers in Delhi and NCR. In teleradiology, and currently she is a consultant at an eminent imaging center in Chandigarh. In addition, she also has made contribution towards MRI reporting of TMJ disorder, salivary gland pathologies, and oral cancer. She has presented papers at various international and national conferences, along with few publications to her credit. In fact, I have seen her, she was very active in our DMFR and IAOMR group, and I could see many of her images which she used to send, and we used to discuss those images. And in that context, I thought it would be best that I get Dr. Neha this time for the MRI lecture. So I welcome Neha, and I hand over the screen now to Dr. Neha Koshal. You can switch.
Hello. audible?
Yes, ma'am.
Yes, yes.
Okay, and thank you, ma'am, for the welcome note. And I think we are running short of time. So I welcome you all to IOMR online lecture series. And today I'll be giving a lecture on MRI, Unravelling Maxillofacial region, an explicit clinical tool revisited. These are the contents of my presentation. I'll briefly talk about MRI, its history, its difference from CT, advantages, disadvantages, machine components. My main focus would be on MRI anatomy and the cases which I'll be presenting. I'll just point out.
आपकी फोटो नहीं आ रही है
आ रहा उसका स्क्रीन नेहा का
नहीं आ रहा मैं बोलने वाला हूँ उसको तो
हाँ उसका स्क्रीन हैंड ओवर करके स्क्रीन
Yeah, Dr. Neha, please share your screen. Your screen is not.
Okay, Okay, just a sec. I'll share. 1 minute.
In fact, we were not able to see your contents also. We were talking about your contents, but we were not able to see
Yes. Okay.
Yes.
Yes, now it's okay.
Shalu ma'am, please switch on your camera.
Okay, but now I can't see my screen. Presenting?
No.
No.
स्लाइड शो कर दो
हाँ मैम मुझे स्क्रीन तो दिखे मेरा
नहीं दिख रहा
हाँ Can everybody see the screen?
Yes.
Now we can.
Okay. So these are the contents of my presentation. How much time do I have? I just want to get away with it.
What is this, Indra Gopi?
Who is this? Indra Gopi. Somebody has shared her screen.
Somebody else is present.
Yeah. I request everybody to please mute and switch off your camera, please.
Shall I continue?
Yes.
MRI stands for magnetic resonance imaging. The imaging plays with the electromagnetic field, the RF pulses.
Is not visible.
My screen is not visible.
Yes.
I had presented, so mine.
Now it's okay. Just do a slide share. I think it's not.
Okay. Now, is it visible?
No, I don't think.
It's visible only in a corner, so.
In a corner.
You need to maximize it.
I have maximized it. This is to my maximum. I don't know why this is coming.
I mean, you can double click it and then it will be maximized.
1 second. Yes, I have put it on slideshow. Okay, maybe I'll redo this thing. And I would request everyone please not to present because. Okay. And
yes, now it's fine.
Fine now?
Yes, now fine. And please requesting everybody to please switch off your camera and mute.
Okay. So, as we all know, MRI is considered a non-invasive diagnostic imaging modality that generates cross-sectional images of the human body without the use of ionizing radiation. Some of the MRI methods, rather all of them, are they use in non-invasive techniques to provide multi-parametric information, function and metabolism. But today I'll be talking about the human anatomy and the pathology part. I will not be focusing on the function and metabolism. These are dealt with very high or specialized sequences and are mostly used for brain imaging. So, MRI entered the clinical arena way back in early 1980s, and within a few years it became one of the most important diagnostic imaging modality, and it still holds this status till today because of its inherent characteristic to feature excellent soft tissue contrast details and also its ability to image in oblique orientations. Now, this ability is very helpful to us, especially when we want to view the TMJ disc, as the condyle is obliquely placed, as we can see here. So, because of these oblique sections, the ability to section obliquely, we can view the disc very clearly. Coming over to the brief history, the foundation of MRI was laid way back in 1952 when Bloch and Koshal had received a Nobel Prize in physics for their developments for nuclear magnetic precision. So the physics was developed in 1952, and later on the application into the clinical arena happened in 1970s. And Dr. Lauterbur and Dr. Mansfield had won the Nobel Prize in Physiology or Medicine in 2003. However, there's some controversy regarding it, and the literature states that it was Dr. Raymond Demadine who had first proposed the concept of MRI scanner, and he was not awarded the Nobel Prize along with the other two, and his contribution was neglected by the Nobel Committee. So this controversy still continues till date. Now, after the advent of CBCT, I think most of us have good exposure to this radiation-based hard tissue modality. So I will not discuss more about CT today. If we compare it, if we compare MRI to it, we know that MRI uses non-ionizing radiation. It basically images the soft tissue of the human body or the maxillofacial region. It is very time consuming, as in the same area of face, which may take less than 10 seconds in CT or maybe around 30 to 40 seconds in CBCT, takes around 30 to 40 minutes in MRI. Also, the contrast which it uses is not iodine, it is gadolinium based. And this is a very expensive modality which at times pinches the patient's pocket. As for the same scan in CT, the MRI may actually cost 4 to 5 times. And its availability is still limited in the country, as the modality is still restricted to cities or large towns. Because the price, it's very costly. It's around 4 crores if we compare the basic 50-60 lakh basic price of CT. But you can't afford. I'm just there is somebody speaking. Please switch off, mute your mic. Now,
Yes, I've done.
Now, if I compare the CT and the MRI machines, they look pretty much the similar. But if we focus on the bore, we can see that CT has a very wide bore. You can see here, so there is no issue with patients who have claustrophobia. Whereas in MRI, this becomes a major concern for such patients. It becomes very difficult to convince them, especially when they are asked to go into a narrow tunnel with a narrow bore, which is very close to their face. So this is one major concern. I'm just showing this picture for the PGs because we keep reading claustrophobia in MRI. So this is how narrow the tunnel is. For such patients, it becomes very difficult to get a scan done and to stay inside the machine for 30 to 40 minutes. Mostly advantages I've discussed. In disadvantages, there is one which is left, that is the metal artifact distortion of the images. Most of the patients coming for a face scan or head scan do have restorations processes or maybe orthodontic bias, and they tend to obscure the diagnostic area, the pathology, or at times the normal anatomy. And at times, these artifacts are reflected even in the brain scan. So many times the patients are asked to get get their orthodontic bias removed or get the prosthesis removed. So this is one area of concern. Now, machine components, as we can see here, this is the patient table and this is the scanner. Now, this scanner is made up of number of coils. There are the radio frequency coils which transmit the signal. The magnet is not exactly the permanent magnet, but these are again superconducting coils. Then they are shimming coils. So the scanner is made up of number of coils, and there is no actual magnet when we are talking about 1.5 Tesla or 3 Tesla. These are superconducting material-based coils. In very brief, I'll discuss how the image is formed. As we can see here, this is the scanner having an external magnetic field. So when the patient is placed inside the scanner, his body's proton ions get aligned along the direction of the external magnetic field. Then the scanner directs radio frequency pulses which resonate the proton ions of the body. Off the coil, the protons give back this energy which is received by the radio frequency coils, and this energy is reconstructed using various algorithms and Fourier transformation as MR image. Now, for head and neck region, there are specific body coils which are used in order to receive better signal. So this is the head coil. You can see the patient is placed, and this is the head coil. And this is the neck coil. Actually, this is the technician who's actually being placed, and this is a CT machine, not an MR machine. He has some pens also. Because if we carry mobile phone inside the MR, it can get damaged. So it was not possible to click it. So just to show you the surface coils, I had asked them to lie down in the CT scanner. So just focus on these coils, and we use these two coils in head and neck region for imaging. This is our console at Atulya. Here the technician sits. This is the workstation where they plan. This is the system for monitoring contrast. So through the glass, you can monitor the patient. Now inside the MR room, it gets very noisy because of the noise made by various sequences, especially the gradient sequence. And this is how it appears. This is how it sounds. So we provide the patients with the headphones. At times, we also play the music in order to calm them down. Now, what are the contraindications to placing a patient in the magnetic field? These were the relative contraindications were once upon a time absolute contraindications, but after the advent of MRI compatible cardiac pacemakers and implanted electrodes, and after the advent of titanium based implants and clips, these have become relative contraindications. Absolute contraindications are cochlear implants, as if you place the patient inside the magnetic field, these implants can get damaged, and they can also damage the tissue around them. Or if there's a case of RTA, or if there's any metallic foreign body which is lying loose in the eye or in the body cavity, they can act like projectile and can damage the body tissues. So one has to be careful when taking history. Now, there are certain precautions which I would like to mention, which are very important because if neglected, they can be fatal. Oxygen cylinder is not allowed and should not be carried inside the MR room, not even near to it. Even the normal wheelchair, we have MRI compatible wheelchairs, and if the patient is dependent on oxygen, the MR room itself has its own oxygen supply, so you can just put the oxygen mask on the debilitated patient. And even the stretcher, we have MR compatible stretcher. You can't use the conventional metallic stretcher. Apart, ATM cards and watches can get spoiled by the magnetic field, even cell phones, and any loose coins or any sharp objects like hairpins, etc., lying in the pocket have to be removed before entering the MR room because they will just the scanner. Now, there have been few deaths also reported in the past. I think this incident, this happened in our hospital. It was sucked in by the machine and he was carrying an oxygen cylinder. So along with the cylinder, he was just sucked up and I think it led to his death. Other case where the ward boy and the technician both were sucked by the machine because one of them was carrying the cylinder inside. Now, the problem with MR is, unlike CT or CBCT, where we just switch them off in the morning and switch them off in the night and switch them on in the morning, you just can't switch off an MRI machine. It is on all the time, because if you switch it off, the helium which is providing the cooling system will vaporize, and the superconducting coils will lose their magnetic field and will become non-functional. And to restart this whole system, it takes approximately 1 week to 10 days. And it's very expensive. It can take anywhere from 30 to 50 lakhs. So it's not only an time-consuming procedure, but also a very expensive procedure. So that's why when somebody is stuck, they try to pull them out maybe manually or use some other innovative techniques. But switching off an MR is not most of the times the option. This was another incident where the guard walked in with the minister and his pistol just flew and was stuck with the scanner. So one has to be very careful when you are dealing with MR machine, and when you are taking the patients inside the machine, you have to be very careful. There should be no oxygen cylinder, metallic wheelchairs, metallic stretchers in and around, or any loose bodies. This is basically technicians' job, so they have to be very well trained. I've just rushed through this part. I'll focus on this part more. This is MRI and maxillofacial imaging. First, I'll describe the MRI anatomy. So these are just pictorial representations. This is a cross section. And here we can see that this is the submandibular gland, 141. This is the hyoglossus muscle. This is the mylohyoid muscle along the inner border of the mandible, along the mylohyoid ridge. And between them, the mylohyoid and hyoglossus, we can see the submandibular duct. These two are the genoglossi. Cornal pictorial representation. This is the mylohyoid muscle, and we have the sublingual space. External to it, we have the submandibular space. This is the exterior to it, we have the anterior belly of digastric. Internal to it, we have muscle. This is the over it we have the genoglossus muscle. Now we'll come to the MR images. Description of anatomy here. This is what we had seen in that shaped mylohyoid muscle attached to the mylohyoid ridge at the alveolar level. We have the of digastric longitudinal fibers. These belong to genoglossus. This of starting from the nose region and nasal, nasal. This part more. This is the masseter muscle. This is the coronoid process. Because this is a bone, it is appearing hypo. In MRI, the bone does not give any signal, it appears hypointense. So this is the coronoid process. So medial to the coronoid process, we can see the temporalis muscle attachment. This is the pterygoid here, the lateral pterygoid. This is the condylar head. This is another section. We can focus on the right side. Muscle, belly. This is the retromaxillary zygomatic fat. This is the condylar head, the fat of the head, and you can see the outer cortical. This is the lateral pterygoid muscle attachment. Now here we can see again the masseter muscle. This is medial pterygoid, parotid gland. If you the parotid gland. Further down, 39 here. This is the submandibular gland. And here we can see distinctly this is the hyoglossus muscle, hyoid muscle. This is the submandibular gland, and in between, these are very important landmarks to identify the submandibular duct. It runs between the hyoglossus, which lies medial to it, and mylohyoid, which lies lateral to it. Region of the submandibular duct. These are the sublingual glands. This is muscle. This is another section where we can see number 46. This is internal jugular vein, artery out here, jugular, the large one, submandibular glands. Here, these are the submandibular glands, and this is the digastric. It lies laterally. This hyper is the facial fat, subcutaneous fat. So after this brief introduction of anatomy, where all can we use MRI? Stated this is a soft tissue imaging modality. So we can think of number of lesions or pathologies for this scanning method. They can be vascular in origin, they can be any benign lesion of the soft tissue, malignancies, like cellulitis affecting the deep spaces, not otherwise routinely, the TM joint, disc, are very important indications. Apart from these, any neural pathology also you can see, especially in Bell's palsy cases or trigeminal neuralgias. I'll start with case discussion. Okay, I'll just briefly talk about the T1, T2, and etc. conventional sequences which have been used in the cases. And this, in order to explain it, I've made some pictorial representations also. On the MRI picture first, we all know, we keep reading that T1, the fat appears bright, the eye fluid appears hypointense or dark, and it is used to visualize anatomy. So what do we mean by that this is used to visualize anatomy? Most of the times if there is any pathology, fluid, etc., so it does not fit on these sequences. Is the normal the structure, some signals which are appearing isointense most of the times, but we cannot or delineate the lesion as such in most of the cases, not all. There are some exceptions. We say that T2 is used to visualize pathology. We all know that in T2, the fat as well as the fluid both appear hyperintense or bright. So as the fluid is appearing bright, most of the lesions, they have perilesional edema or intralesional edema or peritumoral fluid or edema. So this will appear bright and the lesion will actually stand out amongst the normal anatomic morphology. So this was the area which was missing in T1. So this now actually stands out and you can actually see some yellow dots. T2 fat saturation or fat suppressed images. Here what we do, we suppress the normal anatomical area so we are able to better visualize the lesion part or the pathology. I'll be discussing this particular case later on. Here we can see that the facial fat is suppressed and this is the fluid. This is the lesion which stands out amongst the normal pathology. And if we just discuss some anatomy here, we can see that this is the masseter muscle, and in this particular case, we can very beautifully see the parotid duct. These are the salivary secretions, and because they are fluidy, they are appearing and they have given off a signal, and they are appearing bright in this particular section. Even here, we can see the parotid duct. These are the parotid glands appearing isointense. This is how the T2 fat sat works. Now, in contrast enhanced imaging, a lesion, if inflamed or if tumor has very high vascularity, along with that, there is peritumoral perilesion edema also. So it becomes very difficult to actually delineate the true margins of the lesion. So what we do, we suppress everything. We use a T1 weighted image where the fluid is not visible, and we suppress the fat also. And then we give the contrast. So it's just the area which has the vascularity will be enhanced, and the peritumoral margins be delineated in their true sense. And this is again the parotid gland, most likely the retromandibular vein, masseter, medial pterygoid, ICA. Now I'll start with cases. A 7-year-old boy was referred. This is a known case of something which I'll reveal later. He was referred for contrast-enhanced MRI, and the patient had tongue swelling. So you just see that this is a very young boy who's been referred for tongue swelling. So age is an indication here. Now, this is a T1 weighted image. As I had discussed, the lesion is not highlighted or it does not stand out. So since I know the case, I can tell that yes, there is some abnormal signal intensity here in the tongue, which is hypo to isointense, and there is some midline shift towards the right. The moment I put the T2 image, we can see very clearly that there's a well circumscribed hyperintense lesion on T2 with few hypointense linearities in the internal structure. And if we describe its location, it is present in the tongue, extending from the dorsum, involving its entire musculature. This is a sublingual gland, it is present above it. Well defined, well circumscribed, has multiple linearities, hypointense linearities, maybe conglomeration of tubules. This is a T1 image. It does not have contrast. So this is what we had seen initially, that we can't make out much about the lesion. But the moment we give contrast, the lesion enhances intensely. It appears a lot of vascularity, intensely bright on T1 post-contrast image. This was a case of vascular malformation. It was sent to detect the feeder vessels. Now this is MR angiography. Again, good technicians are very important. They have done the angiography here. We can see this is ICA. This is external carotid artery. Some branches, but the lesion is not visualized here. Maybe they scanned or the images they provided is right before the dye could enter the lesion. So I've just put an article here. This is again a vascular lesion, but of the cheek. And here we can see there are multiple flow voids. Maybe because the flow is very fast, the signal got missed, and there are multiple flow voids. Here, this is the contrast enhanced sequence. The lesion is enhancing. And these are the angiographies where you can see the vessels. If we focus on this image, this is a MIPT image, we can see that this particular vessel, facial artery, is actually feeding this vascular malformation lesion. It is feeding this, so this is the feeder vessel. And here we can see another draining vessel. This is a volume rendered image. This is the lesion with the feeding vessel. So this is an added advantage of MRI, that you can actually do angiography, and in cerebral or at times in neck cases, even without contrast, it is possible. Now, this is another case. A 48 years old female was referred for swelling of the left cheek, which was painless but persistent. Now, this is a T1 weighted image. If we look closely, we can appreciate that on the left side, there is a very well defined, almost oval, iso to mildly hyperintense lesion. If we look here, this is the masseter muscle. So this lesion is present anterior to the masseter muscle and the ramus in the buccal space, lateral to the buccinator muscle, and it has not given any hyper signal. It is intermediate in signal intensity. And again, see another lesion in the maxillary sinus. Though our primary concern is this lesion in the buccal space. And on T2 fat saturated image, we see that the facial fat is suppressed. That means the content of this lesion is not fat, it is not lipoma. And here we can see that the lesion gives kind of a soap bubble appearance with very narrow hypo-intense septae. The corticated margin of the lateral wall of sinus is well defined, so this lesion is not infiltrated. It has not eroded the sinus wall, bone, or any structures around. We can also see a hyper intense lesion here. So as the fat is suppressed, both these lesions do not have fatty content. Now this is a pre-contrast image. Here we can see that this lesion is well defined, has few septae, but the moment we give contrast, it appears brightly, intensely bright. Hyperintense has enhanced after giving contrast. Sinus lesion has not enhanced, though we can see some enhancement of the signing lining. So most likely this could be a mucus retention cyst. But what is this lesion which has enhanced brightly after giving contrast? This is, and it has few linearities of hypodensity appearing something like soap bubble. This is a low flow lesion, and later on the biopsy stated that it was hemangioma. So this is another case. A 16 years old female was referred for swelling of floor of the mouth, and thanks to Google and so much awareness on net these days, that she had actually developed cancerophobia. So she was referred by neurophysician to get this scan done and to rule out malignancy. So here we can see a very well-defined oval iso to mildly hyperintense lesion in the floor of the mouth on the left side, and it has a hypo-intense capsule. It is well capsulated. This is a T1 image. These are the submandibular too, and this is the SCM. Now this is an axial section. On the corner section, we can see that this is the lesion present on floor of the mouth, right above the anterior belly of digastric, and this is the sublingual gland, so it is present below the sublingual gland. So that means maybe this is not ranula, which could have been one of the DDs. On T2 fat saturated image and normal T2 images, this lesion is appearing intensely bright. Here we can see that this is a very enhanced or homogeneously appearing bright lesion on T2 fat saturated image. Again, here we can see how well defined it is. Benign side. And when we gave contrast, this lesion did not take up the contrast at all. So that means the internal structure is not vascular, it is cystic. Here we can see that the lesion has not taken up the contrast, anterior digastric. Which we can think of are dermoid cyst, which is usually present in the midline. However, this is laterally placed. We have ruled out. And epidermoid cyst. Logically, this was proven to be a case of In the sinus, we can see that there is some lining, and these are maybe the secretions which have not enhanced after giving contrast. In the previous case, it was a mucous retention cyst. Here, this is just sinus lining thickening. Animation, they have picked up the contrast, and maybe there are some secretions there. This is another case of 15-year-old boy swelling on right side of the face and neck region. Now, this is a massive lesion. We can see that in T1 weighted image, this is the lesion appearing hypointense anterior to the sternocleidomastoid, involving the masticator spaces, spaces. These are the invaded the has not obliterated them but encased them, extending from superficial to deep region around the posterior border of the ramus. Here we can see that the lesion appears pebbled or multiloculated, and it is appearing very bright in T2 image. If we see this ocular fluid and this lesion, the intensity is almost similar. These are the T1 weighted images, the corneal sections. These are the nasal turbinates. This is the tongue. And here we have the lesion. This is the masseter muscle. It is present external to it or lateral to it in the masticator space, extending downwards up to the level of larynx, approaching the submandibular gland space. And we can see here that the lesion has pushed the pharyngeal wall towards the other side and has maybe compromised the airway passage also. The lesion appears intensely bright or hyper intense. These are large cavernous kind of spaces, multiloculated, hyper intense on T2, iso intense on T1, present in the neck region, extending up to the inferior part of parotid gland. These are four images. I'm trying to show the location. This is the larynx. It is present up to the level of larynx. Then around, this is the mandible, going from superficial to deep part around the mandible, and there are some conglomerates or some aggregations of this lesion. It is present in the lobe of the parotid gland also. The inferior lobe has encroached on the carotid space, encased the vessels but not invaded them. Now, surprisingly, this lesion did not take up the contrast. It did not enhance after giving contrast. Kind of lesions in young patients appearing pebbly, multiloculated, intensely bright on T2 images, iso-intense on T1 images, and not showing contrast enhancement. They are usually lymphatic in origin, and I could not get the histopath report for this, but most likely this was a case of lymphangioma, or it could be cystic hydronephrosis. This is another case. 44 years old male patient was referred with tongue lesion suspected of malignancy. Here again in the T1 image, we cannot tell much. All we can see is that there is some midline shift to the right. There is some alteration in MR signal and the morphology. In corneal section, this is the tongue, and we can see that yes, the lingual septum has shifted to the right side. These are the muscles, masseter here, lateral pterygoid. This is the parotid gland here. This is the subcutaneous fat. Now this is the T2 fat set image. This is what I had discussed previously. In T2 fat set, we can see a lesion on the left side of the face, extending from anterior part of the tongue to the posterior part line with and has an invasive border. It has involve the entire anterior and middle part of the tongue from dorsum up to the floor of the tongue, the entire musculature of the tongue, the internal muscles. This is T1 FATSAT image. This is the pre-contrast image, and post-contrast, the lesion has enhanced, and you can actually delineate the true border of the lesion. And this was proven to be a case of CA tongue moderately differentiated. Now I'll discuss some post-op changes in carcinoma patients. 62 years old male patient was referred, and this was a post-RT case of CA buccal mucosa. And patient had a lot of soft tissue inflammation. We can see there is some tongue defect. The tongue appears deficient. Because patient was lying supine, it has actually fallen back and has obliterated or constricted the nasopharynx, oropharynx. And below the tongue, this is the coronal section. This is the deficient tongue, and below it on the floor of the mouth, maybe there is some pooling of secretions which are appearing intensely bright. These secretions. Distinctly see the mandibular bone or the hyoid here. Now, this is how a normal MR picture appears. This is the mandible with the fatty marrow. This is the nerve, inferior alveolar. Then these are the parotid glands. This is the hyoglossus, very hypointense, mylohyoid muscle. This is the duct which will be traversing through them, and genioglossus. So you can actually tell the soft tissue anatomy very distinctly. But if we compare this with our post-RT case, all we can see is a distorted picture of inflamed tissue, some remnants of mandibular bone, and the connective tissue, the muscles, everything is appearing very bright. And that's why the timing of the scan is very important. After RT, after how much time should you send the patient for MRI scanning or even for CT scanning, so that you can actually give a diagnostic report. So that timing is very important. Usually we need to wait till the edema settles down in order to appreciate the defects or the MR anatomical or morphological picture. So because the patient was sent a bit too early, the purpose of the scan was not met here. Case, a 60 years old male patient post-RT. So here we can see this is an axial image. Hemimandibulectomy has been done. This is the left side of the mandible, and the right side has been constructed by a fatty flap. This is T1 weighted image, and we can see that the fatty flap is appearing very bright. On this section, we can see some part of maxilla. The masseter and the pterygoid on the contralateral side are appearing very bulky. They are very bulky. This is not their normal picture, and not even the signal intensity is altered. And we can see these some bright signal here. There are some fatty changes in the structure here. The muscles are not apparent, so maybe even they have been removed after the surgery. In T2 fat side image, because the flap was fatty, it has suppressed, it has not given any signal. And this is the hemimandible on the left side. We can see that the marrow is showing a very bright signal. Usually the marrow in this age group, the red bone marrow gets replaced by fatty bone marrow, and on T2 weighted images, on T2 fat side images, the marrow gets suppressed. As we can see here, we can't see the marrow so distinctly, and these are the inferior alveolar nerves. The marrow is suppressed here in the 60s age group. However, here we can see that it is giving a very bright signal. The internal
Dr. Neha, you are not audible.
I think some network issue.
Yeah, we
Because
have
her
to wait
screen
for
is
a
also,
moment. Probably.
yeah, screen is also improving.
Yeah, screen has also paused. We have to wait for a moment. By the time I request everybody to fill in their details in the form that is being shared with you, so that the certificates can be issued towards the end of the lecture.
I think
Dr.
she
Neha
got
is,
disconnected.
yeah, she's offline.
Yeah.
Uh-huh.
So the session is probably not ended because the time limit is not there with this session.
She got disconnected because of some network issue.
He has to come back again.
Yeah. I'll just check.
Yes, ma'am. We are just trying to connect with Dr. Neha. Probably her phone is not in range. There is some network issue. Kindly be patient and we will soon join back. I hope I'm audible.
Yes,
Yes.
yes, you are.
We're just facing some network issues. So,
Yes, her phone is also not reachable. There is some issue.
Yes, sir.
Yeah, it's audible.
We tried calling Neha. I think there is some problem with the network. Her phone is also coming switched off or not reachable. So there might be some problem wherever she's sitting.
by the time all the participants are requested to just fill in their details in the link provided so that the certificates can be issued to them. And meanwhile, we are just trying to contact Dr. Neha. So the session has still not ended.
No, I just had a
Thank you
talk with
for
her.
Okay, ma'am.
She's coming back. I think there was some network issue. She just got logged out.
Okay.
She's trying to connect.
Okay, ma'am. Everybody's waiting.
Yeah.
We shall all wait by that time.
Yes, yes. It doesn't matter.
There are many people who are filling up the form, but they don't have the LM number or ALM number.
Yes, ma'am.
This time I'll give the certificate, but I request all of you to kindly become member of Indian Academy of Oral Medicine and Radiology so that it will be beneficial for you in a longer run. So you can submit the form without the ALM number if you don't have.
Ma'am, I'm very sorry. I didn't realize that I've been off the screen. Which was the last case which you all saw?
CA. It was, I think, CA case.
CA case was going on.
Ma'am,
Your
the
screen is not-
radiotherapy one?
Yeah, the radiotherapy.
Okay, just let me know which one.
If you can just share your screen, ma'am, we will be able to get it.
Yeah. Okay, I've gone on to TMJ actually. This one, was it this one? Post-RT case?
Yes.
Yes.
That's case number 7.
This one.
Yeah.
This one, where there was a
Yeah.
flap and there was a signal in the marrow.
Yes, case number 7.
Okay, and
Till this screen, I think this one. This was
okay.
So you can
Just
do
start
the-
off with this case again, ma'am.
Okay,
Yes,
okay.
right. Yeah,
Okay.
start.
Okay, so as we can see here, this is a T2 fat site image. Because it is fat saturated, the reconstructed flap has suppressed, the signal is suppressed. Hello?
Yes, you are audible.
Hello?
You are audible, Dr.
Okay. And this is an image of a normal patient of the same age group. Because of the fatty replacement of the in the bone marrow, in the fat site image, the fat has actually suppressed. It should not give any signal. And these are the inferior alveolar nerves, which we can see here very distinctly. However, in this case, there was no fat suppression. On the contrary, the bone was giving a very bright signal. So this was not fat, this was inflammatory fluid. The internal cortical margin is intact. The outer one shows some breach. It is not visualized. And on giving contrast, the marrow enhanced. The case of osteoradionecrosis, where we can see that yes, there are some inflammatory changes inside the bone and there has been breach in the outer cortical margin. Now, this is another case. A 49 years old male patient was referred and he came for the review after 3 years of his surgery. This was a case of CA buccal mucosa post-op. And here we can see that on the right side, there's a large mass which has actually obliterated the posterior choana or the posterior nasal opening, has invaded the nasopharynx. Here we can see in the coronal view, we can see that this is the normal mandible on the left side, whereas on the right side, there is a fatty flap here. And this is the hyperintense lesion, which has actually invaded the airways. This is the zygomatic arch, this dark appearing hypointense bony structure. So this is up to the level of infratemporal fossa and it is very close to invasion or invading the brain also. In the fat saturated image, we can see that there is some altered signal on the right side of the tongue. And here we can see post contrast that the whole lesion has taken up contrast, is intensely bright, has invaded the airways. So this is another picture, pre and post contrast. Pre contrast, it gives us an illusion of being a solid mass, a solid recurrent mass, whereas when we gave the contrast, the lesion enhanced. However, there was a large central area of necrosis. So when we are planning for a radiotherapy or for a chemotherapy, we need to be very careful, as this area will be resistant to treatment. So we really need to plan out our surgeries. Now, apart from recurrence and invading the structures, it had also metastatized to the pons, and this is the cervical 2 or the C2 vertebrae. We can see here, we can see some abnormal signal here in T2, and post contrast, this lesion has taken up contrast. These are the mets in the cervical vertebrae and the pons. So this was the case of recurrence and metastasis. MRI TM joint. This is a cadaveric section, and we can see that the condylar head is in closed mouth position, and this is the disc with its posterior band, intermediate zone, anterior band, and here we can see the classical bow type appearance, bow tie appearance in the open mouth view. This is the histological section. Now, what is the normal position of the disc, and when we say it has displaced? So this is the landmark, the posterior margin of the posterior band position from the condylar head. So this is the line which I have drawn. So this is the posterior band. This is the intermediate zone and anterior band. And some articles have given a range plus to minus 30 degrees, some say 20, some say 10. But most of them agree to, I think, 30. This is an open mouth view where this is the articular tubercle opposing the condylar head, and this is the intervening articular disc or the TM joint disc. This is the superior lamina, temporal lamina. This is the inferior lamina. This is the loose areolar tissue, and this forms the retrodiscal tissue. Anteriorly, it inserts into the capsule and into the condylar head. So after discussing the TM joint discal anatomy in very brief, I'll go on to discussing the cases. Now, this case was referred by ENT to rule out its TMJ origin. Patient was was complaining of non-specific pain in the ear region. This is the right TM joint. The closed mouth view, we can see the condylar head in the articular fossa. View, condylar head opposing the articular tubercle. Here we can see that the disc appears normal in signal intensity, it is hypointense. And here again it has spread out, giving a bow tie appearance. Can you see I've demarcated the disc? This is the disc here, anterior band, posterior band, intermediate zone, somewhat shape here. So this appeared normal in MR signal intensity and morphology on the right side. Coming over to left side, again it appeared normal, kind of. I've marked it here. This is the disc. In the closed mouth view, we can see the condylar head is in the fossa and the classic bow tie appearance, the posterior band, intermediate zone intervening between the articular surfaces and the anterior band. So from TMJ point of view, there was no issue with the patient. This is another case, patient complained of clicking in left TM joint. So this is the right TM joint. In closed mouth view, we can see that the disc has normal signal intensity. In open mouth, we can see the tubercle, the condylar head, posterior band, intermediate zone, anterior band, and the bow tie appearance. So on the right side, it was largely normal in MR signal intensity and morphology. On the left side, if we look carefully, the disc is biconvex. This is the disc, I've pointed the arrow. However, and it is anteriorly placed. This is the condylar head in the articular fossa, and disc is anterior to it, very much anterior to it. It open the mouth to its original position with the normal appearance. So this is the disc here, the convexity, biconvex. Mouth it reduced. So this was displacement. Another case where patient complained of restricted mouth opening and pain in both the joints. Now, if we look here carefully, let's look at the heart tissue. The condylar head morphology evident. You can see an osteophyte here. This is a closed mouth view. There is a shallow preinclined plane. The condylar so-called head is in the articular fossa. And we can't see the disc anywhere out here. It is lying here. It is giving abnormal signal intensity and has a bud shape or folded morphology. So maybe there's some discal tear here. Maybe it has torn from the retrodiscal tissue. The patient tried to open the mouth and the condylar head is still posterior to the articular eminence. The disc has kind of degenerated in the posterior part. It's a degenerative signal intensity. And there is some bright signal here in the superior compartment. If you can appreciate here and here, there is some bright signal or hyperintensity joint fluid or joint effusion on the right side. So we have an abnormal shaped or degenerative disc lying anterior to the condylar head, reduced, and there is joint effusion as well. This is on the left side. Again, the normal condylar head morphology is lost. There is a osteophyte. This is the disc here lying anterior, very much anterior to it. You can't see any connection with the retrodiscal tissue. And again, there is some very bright signal in the superior compartment here. When patient tried to open the mouth, the disc did not move much, did not come back to its original position, intervening between the articular surfaces. Disc, deformed, degenerative disc here, and on close and open mouth. So this was a case of anterior disc displacement without reduction with restrictive mouth opening. Obviously, there are signs of osteoarthritis also. I shared this video in the group. This is a cine sequence. And if we look here, the condylar head has actually moved a little peripheral. The patient puts it back, then the head moves again forward, ahead. So this is a hyper mobile joint, a case of subluxation. And this sequence is known as cine sequence. This is kind of a real-time sequence in MR. So cases, I'll just briefly go through some cases from the articles. First of all, space infection. This is not a common indication for MR as we usually go for CT or other radiographic modalities. But in case if the deep spaces or danger spaces are involved, then you might advise it. Showing swelling on left side of the face. We can see some inflammatory changes in the bone on OPG. This is the MRI picture, and we can see that the whole area on the left side, the subcutaneous tissue, the fat, the muscle, the parotid gland, right, because of the inflammatory fluid, and there are a few air pockets here. These are the abscesses. This is the parotid gland here. These are the masseter and the medial pterygoids. Even they are not distinctly visible because of the inflammatory fluid, the subcutaneous tissue, the fat. And there are some changes in the left eyeball also. There's proptosis. If we compare with the right eyeball, there is proptosis of the left eyeball. And there is some edema or thickness in the adjoining tissues. As we can see here that this was a case of cellulitis and the lesion had actually extended from the temporal fossa all up to the infratemporal region, the masticatory spaces, submandibular space involving the neck and up to the clavicle. And because the parotid gland was involved, the patient had facial palsy. Not very common indication for advising MR. Lymphadenopathy, again, there has been some debate whether CT is better or MRI is better, but nobody has proven or shown any supremacy of one modality over the other. Until and unless there are very specific studies which you want to do, you can advise any of the modalities. Mostly people go for CT. As we can see here, this is a case of metastatic lymph node, and there are multiple amalgamated lymph nodes on the left side which have actually pushed the trachea. And on contrast, they are giving a heterogeneous appearance because of central necrosis. Case of lymphoma, this is an axial view, and we can see that there are multiple enlarged lymph nodes on both the sides. Bilaterally, they are present in the submandibular gland, level 2, near the SCM. These are the large lymph nodes, and this was a case of lymphoma. Node, we can write. Now, MR cytography is a non-invasive technique. We do not use the dye itself, which opacifies or gives the signal. So this is the Stenson's duct here, which we can see. This is before stimulating the parotid gland with lemon. And after the gland was stimulated, we can see defined normal in caliber Stenson's duct. This is a normal picture. Compare MR xylography to DSA or other standard conventional radio xylographic techniques. We can see that this does not show the structures to that extensiveness. Say image where we can see that yes, there are multiple strictures or stenosis. And we can see this is the primary duct, the secondary, and even the tertiary ducts. However, in this MR picture, we can just see the primary duct distinctly with few subtle strictures. The tertiary ducts are not visible at all, and there is some signal in the secondary ducts. So all I'm trying to say is MR xylography is not the gold standard if you want to visualize the ductal structure of the salivary glands. Acute inflammatory infections or states like acute parotitis, or if the patient has any allergy or hypersensitivity to iodine contrast media, in those cases, this can be your modality of choice. From xylography, we can also use, or we do use MR extensively in neural pathologies. Show you this picture. This is the facial nerve, and this is how it appears in MR. This is the fluid around it, and it is appearing hypointense. In the internal caustic matrix, this is the vestibular cochlear nerve. Now, this is the case of Bell's palsy. We all know that in idiopathic facial palsy cases, there is inflammation of the facial nerve in the auditory canal. And here we can see that the nerve is giving off a signal on the other side. So there is inflammatory fluid around the nerve, and because of the compression, patient has got symptoms. So we usually treat it with steroids. So this is how we can diagnose it on MRI. I'm just trying to show the trigeminal nerve in the normal morphological picture. This is the nerve, and this is the ganglion. This is out of scope of maxillofacial radiology because here we basically deal with the brain. But I'm just trying to show you that yes, neural pathologies and MRI indication in such cases, it has a lot of scope and it is very helpful in diagnosis. So I would summarize my presentation, and these are for the PG students that where all can be used MR, wherever you can think of any soft tissue pathology, MRI can be indicated. Not routine modality of choice until unless deep or dangerous spaces are involved. Vascular lesions, USG is the preferred initial modality, and maybe if you want to go for MR angiography to detect the feeder vessel, MRI. For benign lesions, characterization. For malignancy cases, to assess the extent of the lesion and to assess any complications during the surgeries, and especially if we need to take multiple follow-up scans of choice. For assessment of lymph nodes, again CT and MRI both can be used. For neural pathology, like I've stated, the two main nerves which we deal with are trigeminal and facial nerve. In diagnosing internal derangement in TM joint. Salivary is another technique apart from the conventional sequences used in salivary gland pathologies. I would like to conclude. I'm very sorry I went missing in between. IAOMR for giving me this opportunity to conduct the seminar, and I would like to thank you, patient. During this presentation, there were a few hiccups. I would like to thank Dr. Shalu Rai especially for encouraging me and planning this out for me, and our co-host Dr. Dipankar and Dr. Nime Singh. Thanks to the President Dr. Ravi Kiran sir, Tulya Healthcare for permitting me to show their cases. My teacher, Dr. Shailendra Chaturvedi. So these are the teachers who taught me MR, Dr. Shailendra Chaturvedi, Dr. Rajeshri Bahadur, and Dr. KJ Rana. I thank you all for being there for me whenever I need to. Thank you.
Thank you, Dr. Neha, for a wonderful presentation. May I request Shalu ma'am? Yes, Shalu ma'am, please. For the vote of
Thank you, Dr. Neha. It was a wonderful presentation.
Thank you.
If there is any questions, I could see on chat, but in between I got disconnected. So if you have any question, you can come one by one. Dr. Neha. Dr. Arvinda had one question. I could see that.
Arvinda ma'am, where is ma'am?
it is solved.
Yeah, hi Neha. My question was answered in
Hello,
the
ma'am.
presentation.
Okay, ma'am.
You
Okay,
said the MRI is doubtful. I mean, it has the same as CT. My question was one question. If you have
I couldn't get your first question. If I recommend
tissue as well as heart. No, do you recommend for the MRI for lymph node assessment? Both I have a second question. Can you hear me, Neha?
Yes, ma'am. Yes, ma'am.
Both the bone involvement as well as soft tissue involvement. Like in case of tumors, when there is a central tumor and then it invades around, should we go for CT first or for MR? Prefer or both?
Okay, ma'am, your first question is if I'm talking dedicatedly about lymph nodes and not any other related pathology, if I just want to see the lymph nodes and assess the lymph nodes, just see what is their size and at what level they are enlarged and all. I think I would go for the CT modality. Because we need to, see patient's pocket also, and I think there is not much, like I said, it is not superior to MR in that ways, until unless there is some soft tissue lesion involved, which you want to see extensively and in detail. If it's just the lymph node, from CT is as good as MR, and the protocol is you have to take it. In fact, you can take a large area in CT. The protocol goes from T3 level, I think, up to the cervical level for the neck. So that much area in MRI, it's difficult to cover, especially if we are talking about the neck nodes.
Okay.
Question, ma'am, you said that if there is bony erosion, and yeah, it's very difficult to detect very subtle bony erosions. But yes,
Okay.
if there is a mass which is invading the bone, it will definitely gives a signal. So I would recommend, if you have choice between the two modalities, maybe you can go for MR. It depends from clinician to clinician. Some might prefer CT scan for this.
For CT, in fact, I mean, yeah, people are yeah, comfortable with CT and MR. See, the operating surgeon probably CT. Yeah, thanks, Neha. Thank
My pleasure. Thank
She wants to ask, is there any special modification of the parameters for MRI TMT?
Ma'am, I think the sequences are the same. It's just the planning. It's just the sections, and we usually go for a T1 axial, T1 core. T2, I prefer to take fat saturated image in sagittal sections, and PD normal, not fat saturated. And then in open mouth view, we go for plain PD, because most of the patients of TM joints, they come with pain. So, uh, we can, the MRI imaging can actually aggravate the pain. We can't ask them to open the mouth, because one sequence at times takes 3 to 4 minutes. So in open mouth view, we just take PD, that is proton density sequence in open mouth view. The sequences are the same conventional sequences. It's just that they are in oblique orientation. No change in sequence parameters as such. Same sequences, conventional ones are applied.
One more question from Dr. Suma. She wants to know, with dental implant,
Yes.
MRI, MRI is a contraindication even in emergency cases also?
Even in which cases?
Yes. Even in emergency cases, if they want to do an MRI in patients with dental implants, what is the option?
Okay.
A patient with dental implants.
Yes, we are routinely doing MRI in patients with the dental implants, because these days every second or third person has the implant, and most of them are in older age group only. So the only problem comes is with artifacts. It's not that because the implant titanium is not ferromagnetic, it will not get pulled out or anything. It's just that it can cause an artifact in the surrounding areas. It can actually obscure area. Suppose if there's an implant in 4-6 or 3-6, and we are talking about CA of lateral border of the tongue right next to the implant, so then that lesion will get obscured. Yes, so in that cases, it is not a contraindication, but you would prefer to go for a CT modality where you can actually appreciate the lesion rather than just wasting money on MRI. Artifact, definitely an issue with the implants.
Okay. One more question from Dr. Deepa. She wants to ask, some patients are referred by the radiologist, ceramic or metal crowns. Can be removed before an MRI?
See, if the doctor knows that yes, if the doctor is aware, or if he's very sure that yes, these crowns, it's basically the stainless steel crowns which cause a lot of problem. And if the doctor feels, or if the radiologist, I think radiologist knows what he's doing. If the radiologist feels that yes, this crown will obscure the area. At times, they even present artifacts in the brain, though they are present in mandible or maxilla. So, if it's an emergency case, they can't repeat the brain scan again and again. If it's a case of bleed or tumor or anything, for reputation, the center will charge again. So yes, if it's a stainless steel crown, it should be removed. Or even if there's a stainless steel crown, if it's PFM, you need to. I would advise removal of it if it's an emergency case. Otherwise, the diagnostic area can get obscured.
All right. I don't think any more questions are coming. Shalu ma'am, seeing Dr. Neha's presentation in the chat. So I don't think any more questions are there.
So can we, yeah. Thank you, Dr. Neha, once again. And thank you for giving me this opportunity to conduct the webinar. There is some problem in the YouTube. I think I'm not able to share the link there for the e-certificate. So I have told them to mail me in my Gmail account so that the form can be sent to them. Okay.
Hello, yeah, Shalu ma'am.
Yeah.
Ma'am, I have a question for Dr. Neha.
Yes.
Regarding the prescribing of for MRI, like if you're suspecting any lesion, so it is the radiologist who will decide whether they want to see the image in T1, T2, or should we prescribe some, like sometimes I have heard somewhere that you should write sure images if you need for some particular indications. So if she can elaborate about that.
Okay. Basically, for most of the lesions, there are certain conventional standard image sequences which they take. That is T1, T2, etc. But
Yeah.
like I've shown in case of MR angiography, where you want to see the feeding vessel and you want to see the vessels very clearly.
Okay.
Because MR angiography sequence will charge you extra. You need to give contrast. That is another charge. You need to, for the sequence is another charge. And if you are calling the anesthetist.
Okay.
So at times, yes. At times, for specific sequences, the charges are more. For example, for spectroscopy, there's a lot of charge. Or for perfusion or for all those specialized high sequences, yes, the charges are more. So usually the referring doctor, they are aware of the indication of these techniques, and then only they refer. For us,
so we should leave it to the radiologist's discretion which sequence they want to use.
As we are dealing with the facial region, we just want to see the soft tissues, and it's just for vascular that you need to prescribe MRA, or maybe for MR ciliography you can be more specific, or MRT, which has a different protocol. So it's that you just need to write MRI face. If you want with contrast or without contrast, that you can mention, but specific sequences you needn't mention.
Okay. Thank you so much, Dr. Neha.
My pleasure.
Thank you, Shalu ma'am.
Thank you, everyone. Then we should now leave.
Okay.
Thanks a lot, Neha. Thank you, Dr. Nimi and Dr.
Dr.
Dipan.
Neha. Thank you.
Thank you. Thank you.
Thank you. Thank you, everyone.
I'm ending the session.